Good afternoon, everybody. Thank you for being tonight with us in this very interesting webinar. I will pass the microphone to Professor Morozov, who will chair the webinar with me. Peter, it's yours.
Thank you, Professor Fontolakis. My name is Peter Morozov, and I'm Secretary General of the World Psychiatric Association. It's my pleasure, it's my privilege to introduce the first speaker of our webinar, Professor Darrell Regier from the United States of America. He's old friend of mine, and I'm particularly pleased to present Dr. Regier, who is currently a senior scientist at the Center for the Study of Traumatic Stress in the Henry Jackson Foundation for the Advancement of Military Medicine and adjunct professor in psychiatry, Department of Psychiatry, Uniformed Service University of the Health Sciences in Bethesda, Maryland. He also serves as an independent senior scientific consultant at the American Psychiatric Association on DSM-5 and research-related issue. In March 2014, Dr. Regier completed 14 years as APA Research Director and also as Director of the American Psychiatric Institute for Research and Education. Our principal responsibility was to coordinate the maintenance and revision plan for the APA's 5th edition of Diagnostic and Statistical Manual of Mental Disorders, DSM-5. In 2006, he was named Vice Chair of the DSM-5 Task Force to work jointly with the Task Force Chair, Dr. David Cooper. DSM was published in May 2013. Dr. Regier completed 25 years at the National Institute of Mental Health, NIMH, in the year 2000, during which time he directed 3 research divisions in the area of epidemiology, prevention, clinical research, and health services research. Well, I could speak a lot about Dr. Regier, but I take some time from his talk. For that reason, I pass the words to Professor Darrell Regier. His speech will be on interaction of psychiatric classification and epidemiology development. Please, Dr. Regier.
Thank you very much, Peter. It's a pleasure to join you and to have the opportunity to speak about 2 of the kind of driving forces in my own professional career, which have been epidemiology and the classification of mental disorders and kind of the interaction between these 2 and how they complement and are really essential for the full functioning of both of them. Since I've had the opportunity to talk about these forces, I thought it would be helpful to provide some context of how I got into this area. And briefly, I completed my medical training at med school at Indiana University. And during that time, I, along with a number of faculty members, helped to develop a neighborhood health center and a lower income section of Indianapolis. From there, I went to the Montefiore Hospital in the Bronx, New York, to have a internal medicine internship because I was kind of torn in some ways between medicine and psychiatry. However, I went on to the Massachusetts General Hospital for my psychiatry residency. But one of the things that was attractive about this position, where Leon Eisenberg was the chair and Gerald Clareman was one of the leading lights there, along with Seymour Ketty in biological psychiatry. So we had a wonderful opportunity, but for me, one of the attractive features was the Neighborhood Health Center in Charleston, Massachusetts, the Bunker Hill Health Center. And it was there that primary care and psychiatry kind of functioned side by side. And I was interested in actually developing a kind of a research career that would focus on whether or not the kind of close interaction between primary care and psychiatry could actually reduce the prevalence of mental disorders in such a community. And fortunately, Gerald Clareman at the time suggested that if I really wanted to study this, I needed to get some additional training. And he arranged for a fellowship for me to go to the Harvard School of Public Health and to learn about epidemiology and gain some statistical skills to go on from there. It was in 1975 that I completed both the residency and the School of Public Health. And I went over to the Harvard School of Public Health and there met Alexander Layton, who was the professor of epidemiology and psychiatry, who had done some remarkable work in the area of looking at the social context of mental disorders, both in the Sterling County study in Nova Scotia, which he chaired, and then also he finished the Midtown Manhattan study when Dr. Rennie, who was the chair of that, died, and worked jointly with Leo Stroll, who completed the Midtown Manhattan study. It was also there that Layton introduced me to the famous 1957 J.N. Morris book on the 7 uses of epidemiology that included 1, demonstrating historical change, 2, community diagnosis, 3, identifying risks for individuals, 4, analysis of health service use and needs, 5, completing the clinical picture in community studies instead of just in specialty medical settings, identification of syndromes, again, critical for diagnosis, and suggesting possible causes or etiologies that would be based on identified risk factors for prevention and treatment. Now, this agenda was like a bolt out of the blue for somebody who was looking for some keys for a scientific future in evaluating the efficacy of an integrated health and mental health treatment program. However, as soon as I left my residency, I had an obligation to fulfill a military obligation for at least 2 years. This was in the era of the Vietnam War in the US. And I was able to, instead of going into the Army or the Navy, I was able to enter into the US Public Health Service as a commissioned officer and to join specifically at the National Institute of Mental Health. The director of the National Institute of Mental Health Biometry and Epidemiology program at the time was Dr. Morton Kramer, who was interested in developing a primary care research program in his division for a national program in that area. And so he recruited me into the division for what I thought would be a 2-year tour of duty. And then I'd go back to Boston and do my research with the Mass General staff. Dr. Kramer, however, was very active with the development of the ICD-8 and the DSM-1 and DSM-2. And he also had close collaborative relationships with a British psychiatrist, Michael Shepherd, who had established an international standard for epidemiological studies of mental disorders in primary healthcare settings. And one of his students, David Goldberg, who had developed the General Health Questionnaire to screen for mental disorders in primary care settings, was also introduced to me at that time. And both men served as consultants as we developed the NIMH Primary Care Research Program, which evolved eventually into the Collaborative Care Program that Jürgen Unitzer, Greg Simon, and Wayne Caton have developed and spread around the US now. They were at the University of Washington. So with this personal background, I would now like to focus on the legacy of psychiatric classification and epidemiology that I inherited and at the start of my professional career. And I'll do this by sharing some slides with you. So this is the kind of the opening to some assistance from slides that I've put together to help kind of illustrate some of the points that I'd like to make. So we can go to the, there we go. At the turn of the century, 1900 to 1950, there were probably three major psychiatric influences in psychiatric diagnosis. Certainly in the early 1900s, the influence of Emil Kraepelin, Adolf Meyer, and Sigmund Freud were three of the most prominent people concerned with classification. Certainly when Alois Alzheimer in 1906 identified a particular form of dementia that is still identified as a mental disorder that had clear brain plaques and tangles on autopsy. And this kind of set a standard for other mental disorders. Emil Kraepelin described an early form of dementia, dementia praecox, which was later renamed schizophrenia by Bleuler. But unfortunately, autopsy findings did not demonstrate any pathologic findings that could be associated with this biologic categorical disease. There was also then the prominent Austrian psychiatrist Sigmund Freud, who developed an internal psychodynamic developmental theory of the etiology of mental disorders that was more dimensional in nature, with fluid boundaries between different expressions of mental distress. In addition, Adolf Meyer, who ended up at Johns Hopkins in the US, saw mental disorders as reactions to a combination of biologic and environmental causes that were also more on a continuum than discrete forms of illness. Now, the classification of mental disorders and their epidemiology from the mid-1800s to the mid-1900s was primarily the role of mental health hospital superintendents, who needed a way to categorize their patients with severe disorders who could not be maintained in their families or communities. However, there was a typhoid infectious disease epidemiologist, again in the US Public Health Service, an early form of that I had just joined, and who in 1915 was able to demonstrate that pellagra, which resulted in many psychiatric hospitals in the US South, was not an infectious disease, but was caused by dietary infection or dietary deficiency that could be presented as a clear mental disorder, but would be prevented with a balanced diet, including brewer's yeast, which turned out to be a deficiency in nicotinic acid, or vitamin B3, that was only discovered in 1937, long after he had died. And then there was also, if we go to the next slide here, the work of Ferris and Dunham, who were focusing on mental disorders in urban areas and did this ecological study of schizophrenia and other psychoses, and raised the question of whether or not the higher rates of schizophrenia in low socioeconomic areas was caused by the exposure to the stresses of poverty and other stresses in these communities, or if it was a result of a drift down from higher socioeconomic status for people who became affected by schizophrenia. And of course, Hollingshead and Redlich later on in 1958 looked again at social class and mental illness to determine if, and found again that in fact there were higher concentrations of people admitted to hospitals with severe psychiatric disorders in the lower social classes than in the higher social classes. Now, following World War II, let me go back to this first slide, the WHO came into existence, and they actually took on responsibility for psychiatric classification. Starting in 1948, they actually took the ICD-6 and began a series of additions through 7, 8, and 9 that track closely with DSM-1 and DSM-2. But again, the WHO was primarily concerned with morbidity and mortality statistical classifications at that point in time, more so than on the particular etiologies that might be associated with any of these disorders. What happened, though, for WHO is that they were, let me just mention here, these are some of the social class and mental illness rates. They found that 0.8% of specialty mental health services were used in communities with a higher proportion in the lower social classes. But following this period of time, there was really a renewed interest in the degree to which environmental exposures were related to the etiology and prevalence of mental disorders. These included exposures to combat stress, as well as environmental conditions that resulted in high numbers of volunteers being excluded from military service on the basis of a mental health screening instrument called the Army Neuropsychiatric Screening Adjunct, the NSA. And social psychiatrists and epidemiologists, including Leighton, Stroll, and a couple of other psychiatrists I want to introduce to you in just a second here. These were Hollingshead, Leighton, Stroll in the Midtown Manhattan study, and then Pasamanik did a study in Baltimore in which he used the same instrument, but used primary care physicians to identify finally who had a significant mental disorder. Now, during this time, then there was a tremendous amount of interest in the high rates of mental disorders that were found. And I'll just show here that this was a picture that was taken in 1985 at the American Psychopathological Association. And we had here Warren Dunham, who did the Dunham, Ferris and Dunham study. This was Alex Leighton, who did the Sterling County study. Leo Stroll, who did the Midtown Manhattan study. And this is Mort Kramer, who was my mentor. And this is Ben Pasamanik, who did the Baltimore morbidity study. And this is another critical feature person who worked jointly with Mort Kramer and Joe Zubin from Columbia University. And the two of these statisticians were critical in another study that I'm going to get to very shortly. This particular psychiatrist is a Swedish psychiatrist, Essenmuller, who was present at that 1985 meeting focusing on epidemiology. Now, as I said, one of the problems that we had from these early studies is that they were focused on the symptom manifestations without any clear syndrome criteria that could translate into specific mental disorders. So Sterling County had like 51% of the population had current and 57% lifetime prevalence of some kind of mental disorder. Midtown Manhattan said that 81% had mild or greater impairment and 23% significant impairment. And this became somewhat of a problem for psychiatry, that if as many as 81% of the population had a mental disorder, the issue became one of, well, what is normality if that is the prevalence at any given time. As I said, Michael Shepard then was one of the mentors that I had, who had done the major work in London with primary care studies. And here he is in the 1980s receiving a copy of the Festschrift as he was ready to retire from his position there. And he found that about 15% of the population had a mental disorder during any 1 year period of time. There was also this major international pilot study of schizophrenia in the early 1970s. And this is a picture of some of the active participants in this study. I think Professor Morozov would know Dr. Zharikov, Dr. Najarov, and the like. And some of the other people that are familiar are Norman Sartorius, Lyman Wynn, and this is Will Carpenter back here, and a number of other prominent psychiatrists at that period of time. So in the middle of all of this activity in the early 50s, there were so many different schools of psychiatry around the world that the WHO commissioned a British psychiatrist, Irvin Stingel, to survey all of these different groups. And he was able to do a remarkable job in a bulletin of the World Health Organization, of which I have one of the rare copies, in which he basically reviewed all of the Canadian, French, German, Dutch, Danish, Japanese, Spanish, Norwegian versions, and classifications named after particular individuals, Essenmuller, that I showed you a picture of, Jung, Lopez Abor, Langfeld, Shorgan, Rumke, Schneider, and the US War Department. All of these had different classifications of mental disorders, and they all implied different etiologies. And so what Stingel recommended for WHO was that because of the many difficulties created by a lack of knowledge regarding pathology and etiology, these can be overcome by the use of clear operational definitions of the syndromes. He said this approach should lead to a greater measure of agreement regarding the value of specific treatments for mental disorders and greatly facilitate a broad epidemiological approach to psychiatric research. Well, Stingel was ignored after they funded all of this report for the next versions of the ICD for 8 and 9 at that point, which continued to reflect basically a statistical classification without clear diagnostic guidance. Although what also happened about this time was the Mort Kramer and Joe Zubin had noticed in monitoring the admission statistics and prevalence rates of hospitals in the US and in the UK, and actually in New York and London, that there were markedly different rates of schizophrenia and manic depressive illness in these two sites. And they suggested that somewhat like the classic studies of the broad stream pump, if there's a difference in rates, is there a difference in the water, or is there a difference in something that is causing, say, the US to have higher rates of schizophrenia and the British to have higher rates of manic depressive? So they used the same diagnostic interview that was created for the International Pilot Study of Schizophrenia, the present state examination of J.K. Wing, in a US-UK study that demonstrated the need for explicit definitions. And when they applied these explicit definitions, they found that there were virtually identical rates of schizophrenia and manic depressive illness in the two countries, but they were just applying diagnostic criteria differently. And so in the US, what was developing about that same time was the St. Louis, Missouri biological psychiatry group under Eli Robbins and Sam Gazay that came up with what they called the finer criteria. And for any of you who are residents in psychiatry, John Feiner was actually a resident at the university, and he meticulously surveyed people for all admissions that were coming into the hospital and identified explicit criteria for 16 diagnoses. This became then the basis for the research diagnostic criteria that Bob Spitzer used later on. I should mention that ICD 8 and 9 finally did develop some glossary definitions to help kind of normalize the diagnoses across these sites. What happened next, though, was a major change in the field of psychiatry. This is a copy of the Archives of General Psychiatry, and in 1978. The leading article is about the President's Commission on Mental Health that was under President Jimmy Carter. And it was at this point in time that I had come to the NIMH to do to start this primary care research program. And to do so, I developed a kind of a conceptual framework for epidemiologic studies, including Midtown Manhattan and the Baltimore Morbidity study and the Sterling County study, and all read by Mort Kramer in his Biometry and Epidemiology division, where they collected annual data on admissions to all state hospitals, private psychiatric hospitals, general hospital psych units, and collaborated with the National Center for Health Statistics on statistics from all general hospitals. So I was able to get all of the data on what we had on prevalence rates of mental disorders, and identified that about 15% of the population could have a mental disorder and could use mental health services in the course of a year. Now, what I would point out here is that this is the year also that Bob Spitzer produced the research diagnostic criteria along with Eli Robbins. And there were some other major findings that were coming out from Bruce Dorwin, where he had a psychiatric epidemiology and Myrna Weissman, and preparation for this President's Commission on Mental Health. Well, as I said, the paper in June of 1978 basically surveyed all of the previous epidemiological studies and found that in 75, only 1/5 of those were served in specialty mental health, and about 3/5 were identified. Suddenly we had an interruption there. So let me just, okay, so at NIMH, there was an interest in basically studying the mental disorders with a more complete biological approach. There was a kind of a growing emphasis on psychopharmacology in the early 1970s, and NIMH staff had to deal with conflicts between psychoanalysts who thought that these medications were interfering with their treatments. Medications like Thorazine, mood stabilizers like lithium, antidepressants like Interpersonal, and anti-anxiety. And in order to have a common diagnostic approach, they asked Bob Spitzer, who had trained under Joe Zubin at Columbia, and to come and work with Eli Robbins and incorporate the finer criteria for the interview for the NIMH study. And this resulted in the Schizophrenia and Affective Disorder Schedule, the SADS, that used the research diagnostic criteria. And the idea was to develop a longitudinal Framingham study that would look at the longitudinal course then of these disorders. Now, it was in certainly in 75 that I arrived and then developed the paper, that then was adopted by the President's Commission. And in this, we identified that there was really going to be a need with the emergence of the DSM-3 to have a new epidemiological study that could get the prevalence rates for specific mental disorders rather than just different symptom levels of mental disorders. So Spitzer then modified the finer criteria, created the RDC for the psychobiology depression study, and for DSM-3 he modeled it on that, which went beyond the glossary of symptoms to explicit criteria sets that were and this then enabled us to actually develop a diagnostic interview, case finding instrument that Lee Robbins, who was the wife of Eli Robbins and a sociologist who followed very carefully how the residents and staff at Washington University St. Louis actually had come up with their finer criteria. And she developed an interview that could be administered by lay interviewers and could be scored by computer. We can see if that can be advanced. Let me see. Okay. So the epidemiologic catchment area became the first of what we referred to as a third generation of epidemiologic studies. This was followed then by by the National Comorbidity Study that Ron Kessler did after we completed the ECA study in the mid-1980s. And we had put out a request for grant applications to follow up on some of the interesting questions about the comorbidity of mental and addictive disorders that we identified in that study. There was also then Bridget Grant at the National Institute of Alcoholism and Alcohol Abuse, who developed a National Epidemiologic Surveys of Alcohol and Related Conditions, the NESARC study. And then after these took place, we actually went on to work with the World Health Organization for a period of more than 10 years to develop some joint efforts in the classification of ICD-10 and DSM-4. Let me just show you some of the people here that were involved in the ECA. Again, you have Mort Kramer. This was Gerald Clareman. This is Bruce Dorenwind. Jay Burke, who was a colleague with me at NIMH. This is Bob Spitzer. This is his wife, Janet, and Lee Robbins. And this was me in a somewhat earlier phase as well. And we are also pleased to have a number of participants in the ECA study. John Heltzer, who was at the Washington University St. Louis with Lee Robbins, and Dan Blazer, who was at Duke University and headed the epidemiologic catchment area study at Duke. What happened after the ECA, though, is that Gerald Clareman, who is the head of the Alcohol, Drug Abuse, and Mental Health Administration that included NIMH, National Institute on Drug Abuse, and the National Institute on Alcoholism and Alcohol Abuse, felt that it would be important to get a common international classification of mental disorders. And so we went into a cooperative agreement between 1980 and 1994 in which we worked jointly with the WHO. And this culminated in 14 international task forces to examine approaches of national schools of psychiatry And we then had the Copenhagen Conference in April of 1982 with 150 participants from 47 countries. And it resulted in then an agreement to use the DSM-3 as the model for the ICD-10. And in order to do this, we then had this cooperative agreement to work with Norman and the WHO staff as we developed the DSM-4 in the US, the ICD-10 at WHO. And Lee Robbins agreed that she would transform the DIS into the Composite International Diagnostic Interview, which was the interview that would then be used for the World Mental Health Surveys, as well as many other surveys around the world. We also developed the International Personality Disorders Examination, and John Wing's present state examination became the schedules for clinical assessment in neuropsychiatry. Bob Spitzer, meanwhile, developed the structured clinical interview for DSM that was used for clinical research more often in the US than the SCAN, which was used more often in many European studies. But there was also the continued use of the diagnostic interview schedule, and this Audatus was used in the NESARC studies that I mentioned previously. Now, the NIMH ECA study was able to survey almost 20,000 people with 3,500 subjects in each site that were both community and institutionalized populations. And these were just a few of the design issues. We could start with a 1-month diagnosis and see how many people continued with this diagnosis to the end of the year. And that was about 7% of the 18 and over adult population. 9% could start with a mental health diagnosis at the beginning of the year, but did not have it at the end of the year. And then 8% would start at a diagnosis. They would have a diagnosis at the end. They didn't have it at the beginning of the year, and you could see how they would begin in the middle of the year. And then there would be 4% who basically the diagnoses started in the middle of the year and stopped before the end of the year. So that basically you had 12% here new or recurrent diagnoses, and you had a total of the 7% plus 9%, 8%, 4%, or a total of 28% of the population who would have an annual prevalence of mental disorders by the end of the year. And we could also look at this 28% of the population and find out, well, what percent of them could actually be seen for mental health services. And it was only this group up here, 5.9% of the population received specialty care, 5% received care in general populations, another almost 4% in other human services like social work settings, for a total of almost 15% of the population that received some mental health services in the course of the year. 20% were not treated at all in the course of the year. And so it became interesting to find out, so what determines whether or not you're in this group that gets into this group, and what are the risk factors, what are the levels of disability that are associated with these groups as well. As I mentioned, after we finished the ECA, we let out this RFA for Ron Kessler, who developed the World Mental Health Surveys, which have included, at this point in 2004, it was 14 countries in the Americas, Europe, Middle East, Africa, and Asia, and it's expanded certainly somewhat beyond that. So the simple fact that we were able to have these operationalized criteria for specific diagnoses enabled us to do this massive amount of epidemiological work. And this was, these are some of the people who were participating over the years. Ben Locke was the chair of, or the of the epidemiology research branch in my division of both epidemiology and then in clinical research. And these are some of the epidemiologists at the time of his retirement that you may recognize. Again, Mort Kramer, Lee Robbins, Clarissa Canino, Pat Shroud is a statistician. This was Ron Kessler. This is me. This is Evelyn Bromett. And this is blocking for a second here. Let me come back. This is Ken Kendler, who is a very well-known psychiatric epidemiologist at the present time, and has was very active then in the DSM-5 and the revisions of that diagnostic system as well. After working on all of these studies, what we found is that the different surveys did not necessarily come up with the same prevalence rates, which led us to believe that there was something really fundamentally problematic about the specificity of the diagnoses that we had with these criteria. This is a paper that I put out in 1998 looking at the limitations of diagnostic criteria and assessment instruments for mental disorders. So that led me to accept a job then in 2000 to go from the NIMH to the APA to help develop the DSM-5. And so we had started with kind of some presumed etiologies in DSM-1. We had the glossary definitions in DSM-2. We had this paradigm shift with explicit criteria and emphasis on reliability rather than validity in DSM-3. DSM-3R, we broadened some of the criteria. And a very important issue was that the diagnostic criteria in ICD-10 and DSM-4 actually had, in ICD-9, DSM-4, were based on hierarchy, so that if you had schizophrenia, you couldn't have major depression. And if you had major depression, you couldn't have generalized anxiety disorder, or you couldn't have phobias. So what we discovered with the ECA was that you could have multiple disorders if you didn't have the hierarchy. And so we dropped most of the hierarchies in this DSM-3R, and we carried some over into DSM-4, but we also required clinically significant distress and impairment in order to reduce some of the prevalence rates for people who met some of the symptom criteria, but that had no impairment and actually did not want and showed no need for services. So we were interested in a paradigm shift in DSM-5 that would consider more dimensional spectra, development, culture, impairment thresholds for that emerging diagnosis. This was pushed by the high rates of comorbidity, the high use of the not otherwise specified category, treatment non-specificity of our diagnoses, inability to find specific laboratory markers or tests, except for pellagra. We had that one nailed back in 1915. And we were concerned that DSM was starting to hinder research progress. So one of the things that we did is we wanted to go to some more dimensional measures. We introduced some cross-cutting system assessments in DSM. We had diagnosis severity ratings, and we had disability assessments using the WHO disability assessment scale that was developed with Betteron Houston at the WHO, where we developed both the International Classification for Impairments, Disabilities, and Handicaps that then became the International Classification of Functioning, and the HUDAS was the instrument that we developed in this collaborative agreement research study with WHO and the NIMH all the way through to about the mid-1990s when that cooperative agreement expired. So this was the kind of the group of the DSM-5 task force. This is David Kupfer here, and there are a number of prominent epidemiologists that are present here. Here is Norman Sartorius, Bridget Grant again, who did the NESARC study, Jay Burke again, and you'll see Will Carpenter, who sticks out in any group. And we also had David Schaffer, who did a lot of epidemiologic studies in children. This is Helena Kramer, who is a very prominent statistician who kept us focused in some of our epidemiological or field trial studies. But it was a very productive group with, of course, each of these people actually were involved in specific diagnosis work groups. One second. And so the work of classification, though, is never done. And because of some of the weaknesses in being able to correlate phenomenology or phenotypes with genotypes, the NIMH, who was then run by Tom Insel and had Bruce Cuthbert with it, decided that they would develop something called the Research Diagnostic Criteria Framework, the RDoC framework. And what their interest in this is taking a much more biological approach that would basically ask what is the normal distribution of certain trait or characteristics, what is the brain system that primarily implements this function, and how can we understand at various levels of mechanism what accounts for the development or a dysregulation of dysfunction in these systems along a normal to abnormal dimensions. He says it may be more difficult for clinical researchers since the symptoms that they are accustomed to study literally do not appear in the RDoC matrix. And that matrix was basically negative valent systems like acute threat you could do in animal models, positive valent systems like approach motivation in rats, cognitive systems of attention, perception, working memory, systems for social processes, affiliation, attachment, arousal, modulatory systems, arousal and sleep-wake systems. And trying to basically correlate those then with genes, molecules, cells, circuits, physiology, behavior, self-reports, and paradigms. And this is when you would get all the way out to diagnoses. Well, there is a different group who said, if you're going to look at highly dimensional biological issues, you need to look at highly dimensional phenomenology or phenotypes if you're ever going to have a chance to correlate these. So this more intensive investigation of phenomenological clinical symptom and trait dimensions are identified without respect to diagnostic boundaries in an attempt to interface symptom trait dimensions with neurobiological systems beyond the 5 domains of the RDoC. And this is where you get kind of a hierarchical taxonomy of psychopathology, which is this higher order to dimensions where you can start from symptom components. You can go to specific diagnoses according to DSM or ICD. You can break these into various fear, sexual distress, mania, substance abuse, antisocial behavior, and you can break them into internalizing and externalizing disorders in broad groupings. So this is where I've been spending some time. I've also worked closely with the ICD-11 group, with the DSM-5, and we did agree on an overall change in the organization of classification to begin with kind of neurodevelopmental disorders, and then the schizophrenia, mood disorders, anxiety, obsessive compulsive, and so forth. We could actually go between some of the more internalizing, starting with the mood disorders, down to some of the somatoform disorders, and then some of the externalizing, which included some of the addictive disorders, impulse control, disruptive behavior, and some of the other disorders, with a clear break with the neurocognitive disorders and the like. And of course, the ICD decided to break out the sleep disorders and the sexual disorders into a completely different classification. But the question is, can the DSM-5 cross-cutting symptom assessments and the personality inventory for trait assessments prove useful in guiding treatment selection and outcome assessment? Can the RDoC-generated biological variables demonstrate sensitivity and specificity for clinical disorders? And can high-top analyses generate more reliable and clinically useful syndromes than the DSM-5 kind of central tendency diagnoses? We don't think there are firm boundaries between those DSM-5 diagnoses anymore, but they're more on a spectrum. And the assumption is that finding the underlying pathophysiology for disorders like narcolepsy, Alzheimer's disease, or pellagra dementia will trump all other approaches that we may have in identifying diagnoses. So with that, I'm going to stop and see if there are any further questions or comments that you would like to add on where we are in this kind of yin and yang, if you will, between epidemiology and diagnosis. It will be a challenge to use these very highly specified either biological or phenomenological phenotypes in epidemiological studies that will take us beyond where we are with the CD kind of diagnoses. But I think one area that I expect will balloon is more in genetic epidemiology as we go forward with that. I also think that pharmacologic epidemiology, looking at treatment targets that will cross diagnostic boundaries, is another rich area for development for the next phase, what I would call kind of the fourth generation of psychiatric epidemiology. So with that, I'll stop and turn it back over to our chairs.
Thank you, Daryl. Thank you, Professor Aguirre, for your extraordinary talk. And I think the floor is open for question and discussion.
I think we can start with Professor Javed. You might want to comment.
Well, thank you very much, Professor Iger. It was really a very stimulating talk. And you have emphasized and highlighted the importance of epidemiology linking to the classification and just putting a sort of an important question that how psychiatrists should be well versed while they are working on the classification or using the diagnostic criteria. They must have some background information of epidemiology. It was really a great talk, and especially the historical perspectives which you have given that will remind us that how much effort and how much work has been put in to produce and to get what we get in the form of DSM-5 or ICD-10 or ICD-11. I hope that with your expertise, you may be able to comment how this type of classifications and interaction with epidemiology will have an impact, especially in those countries where the resources are very limited or where the psychiatric services are not up to the standard, but people have to use these classifications to communicate not only with the patient, but also among the professional colleagues.
Well, it's a very good question. And I think one of the things that we found with epidemiology is that you had to be able to adapt your instruments to the particular challenge that was needed. So that, for example, Ron Kessler developed something the Kessler 6, 8, and 10 screening instrument for distress. And when, say, New York City needed to be able to do a survey to find out where the various prevalence rates of mental disorder were highest in order to direct resources there, they simply use this very rapid screening instrument. The K6 to identify rates instead of doing a seedy kind of diagnostic interview. And I think what we also found going back to the early work that we did in primary care settings, that the general health questionnaire that David Goldberg developed is used very frequently in primary care settings instead of a full diagnostic interview. And David also developed then the ICD-10 primary care version that is very useful in a setting where on one page you have the kind of rudimentary diagnostic criteria, and on the facing page you have a treatment guideline for how you would approach this. And so that kind of adaptation, I think, has been essential to kind of move forward and to bring mental health services into a primary care setting. In the U.S., the PHQ-9, the Patient Health Questionnaire 9, that has 9 questions that are the criteria for major depressive disorder, with the 9th question being a suicidal ideation question. That questionnaire is now incorporated into many primary care settings and into their electronic health records, if they have them, so that you can track people in terms of what their rates are, their symptom levels are. And what we found is that PHQ-9 identifies people with mixed anxiety, depressive disorders also, and following kind of the outcome of treatment with a simple instrument like this is very helpful. I would mention that David Goldberg and Vedran Ustan and I also worked with the Oxford University New Oxford Psychiatric Text to put out a chapter in that focuses on classification, and we included both the DSM-5, the ICD-11, the ICD-11 primary care that David developed, and the HUDAS, basically the International Classification of Functioning, the ICF, in that, so we could see how these all fit together. But you do have to bring classification down to a level in primary care and in kind of general healthcare settings that WHO has been really a leader in doing this in under-resourced areas.
We are out of time, and Roger is waiting. Hello, Roger. Welcome. But we have 2 questions. If we could answer them in a very
Sure.
short time. The first is why we abandon the hierarchical approach to classification, and the second is whether the distress criterion makes any sense, especially biologically, since we don't use this criterion anywhere else in medicine. I would like to widen these 2 questions. So would you comment on the multiplication of the nosological entities from DSM to DSM? And is there a definition for mental illness?
Well, you have a bunch of questions. Let me just say, first of all, nobody is abandoning the ideological criteria.
Hierarchical.
Oh, hierarchical.
Hierarchical.
Oh, the hierarchical. Well, the hierarchical criteria was abandoned because it suppressed so much information. if a person had, let's say, major depression, but also had significant anxiety and had phobic problems, and also had perhaps some sexual problems, all of that additional information would be suppressed if the only thing that gets diagnosed is the major depression. And so to avoid suppressing that kind of information, we basically introduced a greater level of comorbidity into the classification. So that's the reason for abandoning the hierarchical approach. And certainly it is a much more dimensional approach where you can use this full range of symptom expressions that an individual has in characterizing the patient. And that's going to be critical if you're trying to do genome-wide assessment studies where you have very detailed genomics, and you have just this very gross phenomenology or phenotype to go with your genotypes. So that was the first thing. Now, the second question was, could you clarify what you mean by the move from the DSM-1 to DSM-5?
The abandoning of the hierarchical approach led to a proliferation of nosological and of categories of mental disorders. So if you have a brief comment on that.
Yes, no, it did specifically to avoid suppressing information on the characterization of the patient, because a patient with major depression who has anxiety really will need to have a treatment focused on both that anxiety and that depression. And if they have a phobia, you may also have to do some exposure therapy or the like to deal with the phobia. And so there's and likewise with a whole range of other disorders like PTSD and the like, there are so many different, it's such a heterogeneous disorder that you need to have a full characterization of the patient. And there are different treatments often for different components of a single disorder. So that's one of the reasons for abandoning that hierarchical approach.
Thank you very much for your speech. It was revealing, really, especially for our students who attend this webinar. And it was a unique opportunity to hear the story and the essence of classification from one of its fathers. So thank you very much.
Let me just mention one thing. One of the things that I know is happening now in a variety of countries. One of the lady that I did not mention the second time was Myrna Weissman, and she, along with Jerry Clairman, developed that interpersonal therapy, and a form of psychotherapy that is now being used in the WHO and is spreading around the world, in many cases in Africa and other places. So it's interesting how the epidemiologists, who kind of were in the early stages of this, have branched out into genetics. They've branched out into treatment studies as well, and it's been a wonderful team of colleagues to work with over the last now almost 50 years.
So thank you again.
Sure, my pleasure.
And we will continue with Roger Mcintyre, our second expert speaker. Roger Mcintyre is Professor of Psychiatry and Pharmacology at the University of Toronto and head of the Mood Disorders Psychopharmacology Unit at the University Health Network of Toronto, Canada. He is also Executive Director of the Brain and Cognition Discovery Foundation in Toronto and Director and Co-Chair of the Scientific Advisory Board of the Depression and Bipolar Support Alliance at Chicago, Illinois. His CV is endless, I would say. I am sorry to cut it short, Roger, but it's vast. Roger is one of the most prominent figures currently in world psychiatry, with with an exceptional fingerprint on developments in our field, and not only in isolated areas, but in the global field of psychiatry. So,
thank you. Thanks for inviting me, and thanks for putting this all together. Just want to do a couple of checks if I can.
Could you check your microphone? The volume is rather low.
Okay. Can you hear me now better? Is that better?
Yes, more preferable. Thank you.
Okay. And also, can you see the screen okay?
Yes, we can see it. Perfect.
Okay. And one final question. How much time is allotted to me? I want to make sure I stay on time.
You have 45 minutes.
Okay. Thank you.
As planned.
Okay. Well, again, thank you. And the topic that was assigned to me to address was the biology of mental illness. And when I saw that title as a topic, I thought this presentation is going to take about 65 hours. Obviously a big topic, the biology of mental illness. So what I thought I would do to bring a bit of focus to the conversation, and frankly to reflect the work that we've been doing at my lab here in Toronto, is to narrow the conversation to depression and to focus on one particular effector system, being inflammation. And that'll provide focus. Much of what I'm going to say about depression and inflammation may apply to other DSM-5 diagnostic or ICD-11 diagnostic categories. But I think it's important, in fact, to have a focal point in the conversation. And I thought what we can do is we can begin to walk through this conversation, walk through this topic, and where the opportunity presents itself, I'll speak to its clinical application, and I'll maybe also take the opportunity to speak to some of the research directions and research vistas that are provided by this area. So we're going to start off with a focus on the immune inflammatory system. I want to start off with some very basics. So we are all on a similar language, a lingua franca, and I want to speak to the interface, the intersection of inflammation in dimensional disturbances. Now we're going to focus on mood disorders. We are all familiar that no psychopathology is specific in psychiatry. In other words, pathognomonic for a condition. And we know that there is no zone of delimitation established across mental disorders. Everyone's familiar with the RDoC framework. And a feature of the RDoC framework is that psychopathology is transdiagnostic. And I'm going to focus on different units of analysis. We're going to focus a lot on the aspect of reward disturbances, as well as cognition disturbance. And we'll finish off with perhaps some data on interventions targeting the immune system. So let's begin, if we can, with just a very quick reminder of the immune system. In fact, I think many people have, without request, been receiving an update on the immune system the last 2 years. There's been so much media on the immune inflammatory system during the global pandemic. But just a reminder, we have two parallel overlapping systems, the innate and the adaptive system. The innate immune system is a rapid response system. It involves cells like the macrophages, as well as their relative in the brain, the microglia. It also involves granulocytes, like the neutrophils, as well as the natural killer cells. The innate system is rapid with very little memory or specificity or diversity, and it produces well-known proteins like cytokines, chemokines, cell adhesion molecules, complements, as well as a variety of other chemoattractant proteins. The adaptive immune system is a slow response system. The adaptive immune system involves two cellular populations, B and T cells, and indeed it has a memory. You're relying on the adaptive immune system for the vaccination against COVID-19 as well as other pathogens. The specificity is extraordinary with extraordinary diversity, and you know that the principal proteins are antibodies, and there are indeed cytokines as well, but the principal one for the B cells is in fact the antibody. So we have two discrete systems. And I start off with this just to give us a reminder, but also when we look at in the periphery or in the central compartment across mental disorders that manifest early in life or midlife or later in life, a consistent observation has been disturbances in both the innate and the adaptive system. Now, just a bit more about the innate system. I mentioned in passing that the macrophages, which are well-known cellular components of the innate system, have a companion in the brain called the microglia. When I started as a scientist and psychiatrist in this field, the glia were thought largely to provide anatomical support to the neurons. In fact, when Virchow coined the word glia, glia means glue. And that view that the glia serve largely an anatomical support role rather than any relevant functional role was actually the view till quite recently. Then it was discovered that in the brain of people who have, for example, depression or bipolar or schizophrenia, etc., there were alterations in the size, the shape, the density, and maybe even the population of microglia. We later learned that these microglia populations exhibit abnormal alteration or abnormal activation in select mental disorders, and we now have the ability to image microglia with PET radiopharmaceuticals. And what's also now known is that microglia play a critical role not only in inflammation and structural support, but also in neuromodulation. In other words, they are a principal population involved in glutamate GABA cycling, and we know GABA and glutamate are the most abundant neurotransmitters in the brain. The cellular system, the adaptive system, and the system overall, in the humoral system are listed here. And again, we'll get into this a bit later on. But for example, when you look at antibodies to protein or to bacteria, or other types of species, viruses in people with depression, we begin to see some signatures that are a little different on average when compared to the general population. Let's, if we can now, just talk a little bit about a unit of analysis at the cellular level, that being the astrocytes. So I've shifted now from microglia to astrocytes, a different population of glia in the human brain. And a moment ago, I had mentioned that that there are alterations in the size, the shape, the density, and the function of glia in people with stress-related disorders like depression, psychotic disorders, and so on. And we know from diffusion tensor imaging studies that the functional connectivity, more specifically the anatomical and functional reciprocity, is altered across mental disorders like depression. Here's a proof of concept that when astrocytes in cell culture are exposed to elevated levels of inflammatory markers, in this case interleukin-1 beta or tumor necrosis factor alpha, over a period of 1, 2, 3, 4 days, you begin to see progressive loss of astrocytes. Now, in a moment, we'll come back to these cytokines. They are some of the most replicated cytokine alterations in depression. But a hypothesis with us for quite some time now has been that disturbances in inflammation may in part through their effect on, in this case, white matter, be responsible for apoptosis, premature cell death, and loss of cellular density. And in the case of white matter, it's referred to as neuropile. In the adult with major depressive disorder, the most replicated volumetric abnormality is bilateral in some, unilateral in other, loss of hippocampal volume, which is now known to be a loss of neuropile or white matter. Now, we're looking at a slide now that evaluated humoral immunity, specifically antibodies to cytomegalovirus. And cytomegalovirus tends to be a quiescent virus. It tends to reside asymptomatically and typically in the brain. And cytomegalovirus infection is very high across different populations. And it tends to reside in the stem cells or the progenitor cells, especially in the dentate gyrus, which you all know is a pre-processing area for the hippocampus. And this is one of many studies that have been looking at the relationship between brain volume in a region of interest, the dentate gyrus, which is known to be altered in morphometry across severe mental illnesses, and its association with serostatus for cytomegalovirus. And what you can see here in men who have severe mental illness, schizophrenia, etc., bipolar, there is in fact a decrease in dentate gyrus volume that seems to be associated with seropositivity for the CMV virus. Now again, this is association. Everybody's aware of the Bradford-Hill criteria, association versus causation. But this adds to a very large body of evidence associating infection, especially during critical periods of development, to mental illness. And I think everyone on today's program would be aware that in utero exposure to viruses like cytomegalovirus or herpes simplex virus, toxoplasmosis, other pathogens, is associated with later manifestations of psychotic illnesses, mood disorders, mental retardation, as well as autism. This has now been published. This was about 3 months ago. We published this in JAMA Psychiatry. Felicitas Siban's part of my team. We discovered that if you have a mood disorder, either major depression or bipolar disorder, you are at greater risk relative to the general population of being infected with COVID-19, being hospitalized with COVID-19, and dying because of COVID-19. And about 4 weeks ago, the Centers for Disease Control and Prevention in Atlanta updated their list of pre-existing conditions that put people at risk of COVID and its complications to include now persons with mood disorders and schizophrenia. Now, many might be wondering about this analysis because these persons often have concurrent conditions like heart disease, type 2 diabetes, obesity, or behaviors like smoking that are also shown to be risk factors for COVID and its complications. And we tried to adjust for all of those factors to the extent that we could, and the risk still prevailed. And what I would say is that this is not simply a statement about immune dysregulation. This is a more complicated narrative that involves social determinants, access to healthcare, spatial environment that people live in, congregate settings, but to some extent may also involve aspects of the immune system, but goes well beyond the scope of that topic. To keep in the theme, or keep on the theme of COVID, is that this report appeared about, a year ago or so, 9 months ago, documenting a rate of neurologic and psychiatric disorders in people infected with COVID approaching about a third. And this is a historical event that had a footnote. There's other reports like this. For example, the Spanish flu in the 1920s, we saw an increase in rates of neurologic and psychiatric disorders. Some remain very mysterious, like encephalitis lethargica, many others. But the point is that we're scratching our head as to what the mechanism is here. You would not expect, and nor is there a simple explanation. Moreover, there's not one single explanation. And there's not any one explanation that's mutually exclusive of another. But certainly it's a testable hypothesis in some of these cases that the manifestation of neurologic and mental illness may in part be a result of the immune reaction to the COVID-19 virus. Let's, if we can, go back to depression. Now, in people who have depression, around 25 to 40% of them exhibit peripheral alterations in cytokines that are produced by the innate system largely. And the most replicated cytokine alterations are listed here: interleukin-6, CRP, and TNF-alpha. And this has been observed across populations. A more consistent observation is that cytokine elevation is typically prominent in individuals who report childhood trauma. Childhood trauma and depression seems to be discrete neurobiologically and phenomenologically from major depressive disorder without trauma. And one of the observations is an elevation of inflammatory systems. We also are more likely to see increased inflammation in people who have concurrent conditions like obesity, as well as people who are treatment resistant, at least treatment resistant to monoamine-based and specifically serotonin-based antidepressants. The most replicated of all of the cytokine alterations, although it lacks specificity, is elevations in CRP. And you all know that C-reactive peptide is produced by the hepatocytes, by the liver cells, and they're triggered by the elevation in interleukin-6. So interleukin-6 instigates an elevation in CRP. And this has been a frequent observation in our field. Now, we all are aware that the peripheral doesn't necessarily mimic the central compartment. So what about the central compartment? Well, these are obviously much more invasive to have access to cerebrospinal fluid. But what is there, in fact, whether you're looking at animal models of stress or looking at human subjects as we are right now, there's a consistent finding of, again, elevated pro-inflammatory cytokines relative to healthy controls. So the observation of elevated cytokines in the periphery is also matched by elevated cytokines in the central compartment. Now, one of the important proteins that's produced by the innate system is complement. What I also want people to begin really thinking about is not the association between inflammation and depression, or inflammation in any one DSM or ICD disorder, but instead to think about the association between inflammation and dimensions of psychopathology. One of the most replicated and robust observations is elevations in select cytokines or complement in measures of inflammation, measures of anhedonia and cognition. These are often manifesting as apathy, amotivation, psychomotor retardation, as well as cognitive impairment. And so when we look at the DSM-5 criteria, for example, the 9 criteria, of those items, disturbance in cognition and reward have the tightest link to alterations in inflammation. Now, many of you would be aware of the fact that when you have an elevation in inflammation, that triggers a cascade of events wherein we begin to see relative depletion of monoamines, serotonin, dopamine, and norepinephrine. For example, when you activate the immune system, that activates a separate protein called indolamine 2,3 dioxygenase, which shunts tryptophan away from serotonin synthesis towards the creation of metabolites, which include, but are not limited to, quinolinic acid and kynurenic acid. And some of these metabolites, like quinolinic acid, are directly neurotoxic. They, in fact, create an excitotoxicity. Other colleagues have shown that in adults with depression, when you look at the basal ganglia, for example, elevated CRP is accompanied by an increase in glutamate availability in select brain regions. This is important to highlight because there's now a story unfolding that perhaps glutamate increase is what's accounting for apoptosis in the brain in states of inflammation. It also provides a separate testable hypothesis that in states of inflammation in depression, perhaps drugs or other interventions that may target the glutamatergic system may be more appropriate. From an evolutionary perspective, we do know that there are advantages to the immune system. Clearly, evolution would have rewarded animals that were capable of robustly fighting infection as well as healing wounds. The immune system, when activated in lower species, causes the animal to exhibit increase in anxiety-related behavior as well as psychomotor retardation. This makes evolutionary sense as the conservation of energy would be required to fight the infection and heal the wound. In human subjects, in volunteers, there's what's called endotoxemia models where you can actually provoke the immune system using a protein. It could be bacillus. It could also be lipopolysaccharide, which is most often used. Lipopolysaccharide, or LPS, is a protein on gram-negative bacteria. And when you inject that LPS into a volunteer, a healthy subject, in the MRI scan, you begin to see activation in the cingulate cortex. You also begin to see decreased activity in the striatum, in the basal ganglion. In other words, what you're observing is an increase in activity in the brain region that subserves hypervigilance, as well as a decrease in activity in the brain region subserving fatigue, apathy, anhedonia, amotivation. In the short term, that serves evolutionary purpose, but in the longer term, it creates a phenomenology that is mimicking depression. And when we see people who have depression, they complain of fatigue, apathy, amotivation, anhedonia, as well as anxiety. This is one of the more powerful proof of concepts of the link between inflammation activation, brain changes, and surface-based phenomenology. Earlier, I said that inflammation and its association, perhaps even causation, of phenomenological characteristics of depression is most robustly established for disturbances in reward, broadly defined, as well as cognition. Remember, reward is not just simply the absence of pleasure, it's the absence of anticipating pleasure. It's also the absence or impairment in reward-based learning. Cognition is a big topic. It can be considered or conceptualized as disturbances in executive functions, memory, processing speed, and attention. And all atoms of cognition, as well as all subdimensions of reward, are reported to be abnormal in people with depression, as well as most robustly associated with immune inflammatory changes. So far, I've not really spoken about etiology. A lot of this is cross-sectional. This is association work. Can we really say that it's actually causative? Well, we have some leads. We know that sources of immunoinflammatory activation are many. There are GWAS studies that hint at SNPs, or single nucleotide polymorphism, relevant to the immune system, like the HLA system. But there's many environmental factors like poverty, trauma, loneliness, sleep disturbances, comorbidity like obesity, the diet, microbiota. The single most important risk factor for all mental illness is childhood trauma. We know that the population attributable risk of trauma towards depression approaches 50%. In other words, up to 50% of the vulnerability to depression is because of trauma in some studies. So the immune inflammatory activation in many cases may be an effector. In other cases, perhaps it plays some role in etiology. This was a wonderful study that was presented in the American Journal earlier this year, looking at children of poverty. And my message is that psychosocial stressors, especially early childhood stressors, which is the most powerful risk factor for mental illness, is associated with inflammatory changes as well as brain changes that subserve the phenomenology we see. In the United States, about 20% of children live below the federally defined poverty threshold. This study was done in a region of Chicago where poor children participated in this study. They had blood sampled and they all had MRI scans completed. While in the MRI scan, the participants engaged a paradigm to provoke fear reaction and reward reaction. What was interesting is that in these young children who don't have mental illness declared yet, they're exhibiting alterations in amygdala response, in response to, for example, a fearful stimuli. And this response was highly associated with inflammatory changes. The reward system, specifically the striatal system, also exhibited alterations in these poor kids. And that association, again, was highly associated with changes in the immune inflammatory system, even after adjusting for the HPA axis and other stress response systems. So this is in fact real-world ecological evidence, mimics what we see clinically, insofar as psychosocial stressors set in motion subclinical alterations in brain function in those brain regions known to be abnormal, not just in depression, but also a tight correlation with inflammatory activation. My team recently reviewed this literature on loneliness. We are social species. The world's never been so hyper-connected through internet, but never so lonely. And we now know, based on studies, that loneliness is another pandemic around the world, some people more than others, especially younger people. A separate conversation for another day is perhaps in part why younger people are faring so poorly during COVID from a mental health perspective is because of amplification of loneliness, which is worse in younger populations. What I wanted to underscore is that loneliness is linked to an activation of the immune inflammatory system. It is perceived by the animal, in this case human beings, as being a threat. I would conjecture that maybe in part why some of the vulnerability of loneliness, which is linked to depression, anxiety, suicide, obesity, and many other problems, is in part because of its association with activating of the immune system. I said a couple of times that childhood trauma is the most replicated risk factor for mental illness. The population attributable risk of trauma and depression approaches 50%. These are data in adults with depression showing that childhood adversity is highly associated with activation of these systems. These are in people with mental illness. The earlier study in Chicago was in young children who had not yet declared mental illness. Certainly comorbidity can play a role. Adipocytes, when people begin to accumulate more adipocytes, it often outstrips the oxygen supply. That leads to necrosis and the expression of what's known as DAMPs, or damage-associated molecular patterns. This triggers the immune system, and the immune system then triggers the production of other cytokines from adipocytes. Is the elevation in inflammation and depression only because they're more likely to be overweight and obese? No. After you adjust for obesity, you continue to see this association. But it is true that people with very severe obesity, that is people with BMI over 40 kilogram per meter squared, are much more likely to exhibit mental illness when compared to people with overweight obesity below 30 kilogram per meter squared. We're reminded that body mass index is an imperfect proxy of the immune inflammatory system, at least in people who don't have very severe obesity. Now, there's many different examples of how CRP elevation is temporally associated with the onset of mental illness. There was a paper that appeared in China, this study showing that elevated CRP, or dipeptidyl peptidase 4, another inflammatory protein, prior to the onset of mental illness is observed. The UK Biobank study that appeared in the American Journal about a year ago documented elevations in inflammatory markers prior to the onset of depression, although accounting for relatively low variability, about 3%. Some have asked me if inflammation accounts for only 3% of the variability in risk, is that relevant? And the answer is yes, it is, because we know from polygenic risk scores, PRS scores, that today in 2021, polygenic risk scores account for between 4 and 7% of the risk for major depressive disorder. So it's certainly within the proximity of what we see with polygenic risk scores. Remember I said that inflammation is linked more to reward in cognitive disturbance? Many studies, this is just one, showing that increase in IL-6, again, IL-6 provokes the production of CRP, is highly associated with impairment in immediate and delayed verbal recall, a very common observation in people with depression. Elevated cytokines linked to fatigue, which is often a disturbance in anticipatory reward, one of the more replicated associations in this field. What about the relationship between increased inflammation and response to antidepressants? Well, antidepressants are mechanistically dissimilar. We have differences pharmacodynamically and kinetically within class and across classes. But there has been an observation, replicated multiple times now, that SSRI antidepressants may not be as effective in people with elevated CRP. In contradistinction, norepinephrine-based antidepressants like bupropion or nortriptyline may be highly effective, more effective than SSRIs in people with elevated CRP with depression. Does this mean that we should be checking CRPs at the point of care for patients with depression to identify a biophenotype more likely to benefit from one type of antidepressant versus another? Not yet is my answer to my own question. I don't think we've sufficiently demonstrated its clinical utility or its cost effectiveness, but it is an area of pursuit. In contradistinction also to SSRIs, I said bupropion and nortriptyline seem to work quite well in people who have elevated CRP. Ketamine, which has been shown to exhibit rapid antidepressant effects in adults with treatment-resistant depression, also seems to work especially well, at least in some early studies, in persons with elevated inflammation. This is a protein called adiponectin, which is an anti-inflammatory protein. When it's low, it indicates, or it's a proxy for inflammatory status. We have also found at my center in Toronto, where we've given thousands of infusions of ketamine for depression and bipolar depression, that this treatment's especially effective for people experiencing anhedonia, that is apathy, fatigue, anhedonia, as well as amotivation. What's interesting is that, remember earlier I said that increased inflammation is accompanied by an increased glutamate level in the ganglia? It's a hypothesis that a glutamate modulator may be preferentially effective therein. There are some other treatments that seem to work a bit better in people who have depression and elevated CRP. One is omega-3 fatty acids, specifically eicosapentaenoic acid. In this case, L-methylfolate, 7.5 to 15 milligrams, especially with high body mass index. Rather than going through one example after another, maybe I'll just stop there and summarize my point. The point is that we have different biophenotypes. I happen to think that depression with trauma, that is DSM-5 defined depression or ICD-11 defined major depression with trauma, is a very different neural and phenomenological disorder than DSM-5 or ICD-11 defined depression without trauma. And it seems to me that in part, the difference rests on the different biosignature, the biophenotype, if you will, broadly involving inflammation. A whole host of post hoc analysis where people have gone back looking at a variety of drugs, in this case, lurasidone, a second generation antipsychotic, showing that benefits with some of these treatments may be moderated by, again, peripheral inflammatory status. So again, this is obviously a very active area. I don't think it's resulted in any call to action yet with respect to testing these markers, but you get a sense of where things are going. Now, perhaps in fact, where the story around the association becomes causation, that is, do cytokines cause depression? I think the best proof of concept is people who in fact are treated with drugs like interferon or drugs that are known to activate the immune system, but themselves are also cytokines. So interferon, pegylated interferon, appears to be the most depression-causing drug we have. With rates of depression, new onset approaching 30 to 50%, people who take this, for example, for malignant melanoma, other conditions, and antidepressant prophylaxis seems to cut this risk in half. That's a reminder that many of our antidepressants may in fact have immune modulatory effects. No doubt you all saw this report about a year ago in JAMA where fluvoxamine, yes, we know it as an SSRI, but it's also a sigma-1 agonist. Sigma-1 is a chaperone protein that's embedded in the endoplasmic reticulum that modulates the inflammatory system. These investigators at Washington University in St. Louis showed that in people infected with COVID-19, these are not people with mental illness per se, they have COVID-19, and they treated these people with fluvoxamine compared to placebo to see if that could reduce the complications from COVID, like a low oxygen saturation, and it did just that. 2 weeks ago in Lancet Global, this study was extended and replicated in a sample approaching 1,600 people, showing again that fluvoxamine decreases complications from COVID. Now, my point is not so much to speak about COVID and how to manage COVID. My point is that our drugs have effects on the immune system, drugs that are conventional drugs. Of course, lithium has been known for a long time to do this, as do other agents like atypical antipsychotics. What's the evidence that anti-inflammatory drugs can mitigate depression? Well, the evidence base around this would support the conclusion that there are in fact evidence for statins, minocycline, omega-3s, that these drugs can reduce depressive symptoms. Why we still don't recommend them though in clinical application as a routine is these studies are often very small with tremendous heterogeneity and bias, which limits a definitive conclusion. I'm staying on the theme with COVID purposely because of the time we're in and because of the observation of its link to mental illness. I also wanted to bring to your attention something that's been observed now for a decade or so, and that is across different vaccines like the flu vaccine, varicella-zoster vaccine, measles, or hepatitis C, adults with depression may not have as robust an immune response to the vaccine. What's interesting in this report, which I thought was really cool, from Irwin et al. At UCLA, they showed that people with depression who receive varicella-zoster vaccinations who are elderly exhibit a diminished immune response to the vaccine. However, if they're treated with an antidepressant, the immune response is recovered. Now, earlier I told you some data we published in JAMA Psychiatry showing that people with depression are at greater risk of infection and complication and death due to COVID. We will have to keep a close eye on whether or not people with depression are in fact going to exhibit a sustained immune response to the vaccines when compared to other individuals, healthy, otherwise healthy people in the general population. For those of you who work in medical settings, you'd be familiar with drugs like infliximab, adalimumab, uskemivab. These drugs are used for psoriasis, ulcerative colitis, Crohn's disease. These drugs show significant benefit on measures of reward like anhedonia and fatigue, quality of life, as well as cognitive functions. We decided to test this hypothesis with a proof of concept study giving adults with bipolar depression with trauma and or elevated CRP levels an anti-TNF drug called infliximab. What we found in the undifferentiated, the full analysis sample is that infliximab, an anti-TNF drug, is not more effective than placebo at reducing depressive symptoms. In the protocol, though, we said we were also equally interested in looking at people who've been traumatized. because this is a group that's common, at least half of people with depression or bipolar, and they're more likely to have an inflammatory biophenotype. And what we found was the anti-TNF drug was superior to placebo in this population. I mentioned earlier that we have data for statins, and these are some data showing antidepressant effects. These are anti-inflammatory drugs. But again, I don't think we can recommend these drugs as antidepressants given how small these studies are. When asked the question, can we prevent depression? The answer is yes. There's data showing that statin utilization in the post-cardiac event patient has been shown to lower the risk of overall depression. Finally, exercise, which we now know to have protective effects on the incidence of depression, maybe even treatment effects on mild depression, as well as psychotherapy, another powerful modality of treatment, have anti-inflammatory properties. There's data for CBT and mindfulness that it behaves as an anti-inflammatory agent. We also know that when you get a good night of sleep, that's also associated clearly with anti-inflammatory effects and improved well-being. And there's a lot of interest in so-called chronotherapeutics. For example, lithium is a chronotherapeutic. There's a new class of drugs, or relatively new to psychiatry, called orexin receptor antagonists. There are the single or the dual orexin receptor antagonists, the SORAs and DORAs. These drugs are approved in some countries around the world as hypnotics, but they're also being developed by many sponsors for the treatment of depression, and they seem to have anti-inflammatory properties in some paradigms. Earlier, I had mentioned that social connectedness, when it's broken, that is loneliness specifically, is associated with increase in inflammation. It'd be an interesting study to test whether or not strategies to reduce loneliness can also be anti-inflammatory. We now know from a paper published just 2 weeks ago that people who are lonely are more likely to be prescribed antidepressants, hypnotics, and benzodiazepines. We wonder whether or not the loneliness provokes, among other things, the immune system, setting in motion, again, a cascade of events that leads to the phenomenology of depression. A lot of my colleagues are looking at diet, Mediterranean diet, Greek diets, omega-3 diets, fish diets, ketogenic diets. I don't think we can recommend anything just yet other than just a healthy diet, which in and of itself is very difficult for too many patients because of economic insecurity and food insecurity. Nonetheless, there are data to suggest that some of these interventions could have anti-inflammatory properties. And finally, the gut microbiota or the biome, we are looking at this, others are looking at this. Is it playing a role in the pathogenesis of depression? We don't know, but it certainly is in fact associated with alterations in the immune inflammatory system. And there's been a variety of research studies underway testing the hypothesis that reducing the change in the enterotype, in other words, the bacterial signature, where we see less diversification of species in depression, if we re-fortify, if you will, if you fortify the diversity, that may have anti-inflammatory properties, which leads to reduction in depression. So I purposely wanted to focus on the immune inflammatory system as a single thread in this cloth of pathogenesis and pathophysiology. I wanted to focus on depression as the exemplar diagnoses. Really, in fact, what I would argue is that inflammation is not linked to any mental illness. What it's linked to is disturbances in dimensions of psychopathology, like rewarding cognition. And we have different units of analysis, from the genetics, epigenetics, through the proteins, the cells, the circuits, and the networks, but I have purposely just tried to keep it brief and succinct. And we have convergent lines of evidence that disparate modalities of treatment in depression have differential effects on innate and as well as the adaptive immune system. It's not outside the realm of possibility that future therapeutics in psychiatry may deliberately attempt to target these systems. And there are many sponsors right now who are beginning to look at this very question. With that, I want to thank you all for giving me this opportunity. I'm open to answer any questions as they may come up.
Dear Professor Mcintyre, thank you for your excellent and very comprehensive talk. There is one question by Senad Hasanazic. can you eventually end up considering some forms of major mood disorders like bipolar disorder or major depression and maybe Alzheimer's dementia as early trauma-related disorders?
Yes, you can. So again, in psychiatry, in the DSM and the ICD, early trauma is the most relevant risk factor for mental illness. And the population attributable risk, not just in depression, but also in severe, persistent, lifelong illnesses like schizophrenia and bipolar, are also quite significant. In addition to being associated with mental illness, early trauma is powerfully associated with cardiovascular disease, diabetes, obesity, and many other chronic non-communicable diseases. So the notion that trauma, especially trauma during periods of critical development, set in motion off-trajectory development, which ultimately leads to a higher rate of an earlier age at onset of disorders like depression, like Alzheimer's, is certainly well within the realm of possibility. So I think that that's the observation, but there must then be an opportunity. There must be an opportunity provided here. And the world has gone through an incredible trauma the last 2 years with the pandemic. There's been bereavement, there's been loss of life, there's been a massive increase in global poverty, there's been an increase in domestic partner violence, especially amongst women, an exacerbation of loneliness, especially in younger people, but others as well, of course. And so there's a tremendous opportunity here at the population level for us as governments and as a communal agency, in fact, to work together to find ways to reduce the hazards of this trauma. What caught my eye about 6 months ago is a report that appeared in JAMA, where a relatively low-tech, low-cost, high-scale intervention, reaching out to lonely people at home and just chatting with them over the phone, just for a short period of time, 10, 20 minutes, could reduce loneliness, reduce depression, reduce anxiety. And I think these are some of the types of strategies we're going to be hearing a lot more about, these types of scalable, population-based programs to address the trauma that the world's going through.
I have a few questions myself, but I will wrap them in a single one. Have we solved all these methodological problems? For example, we're not really sure whether mental disorders, even schizophrenia, have any brain atrophy. Large groups of patients do not have atrophy at all. And then how can we be certain that we have neuron loss because of apoptosis? Apoptosis leaves nothing behind, so we can never be sure.
Right.
So also there is a big problem with the methodology of MRI, structural MRI studies. If you're spreading, if you are stretching the brain on a Talaraya atlas, I'm not sure what's the so have we solved all these problems and start discussing about refined findings and the pathogenesis. And let me ask you a final thing. If you have a traffic accident and you are getting into an ICU, then you are probably having an immune reaction. And you will probably have, not certain, you will have antithyroid antibodies. That's a non-specific reaction. So why should we consider immune reaction as a cause and not as an effect of the severity?
Yeah, that point's extremely well taken. I agree with you. And your point on MRI scans is well taken. The smallest resolution we have on a voxel on the MRI is like a couple of millimeters. That's still enough for 50 to 75,000 neurons. So the resolution is completely imperfect. So I think, in fact, what we need to do is we are really resting on convergent lines of research, looking at, for example, molecular and cellular research and the effect that inflammation does have on cellular integrity and function, especially in brain. I think where the thinking needs to change is in the very first part of the thought process. We have, since I've been in this business, I think long before I came into psychiatry, we've been looking for a singular explanation. We've been looking for an encompassing explanation for schizophrenia, autism, bipolar depression, and it doesn't exist. And I think inflammation is totally not relevant to many people with depression. I think it has no relationship to their illness whatsoever. But I do think that depression is, I don't think this, I think the evidence supports this, is a group of thousands of disorders perhaps. And the role of inflammation is only relevant to a small group. Maybe, I don't know what that is, but we know that, say maybe 10 to 40% exhibit changes in inflammation. The UK Biobank data indicates that inflammation accounts for about 3% of the variability in depression. That's relatively small. And some people would say that's so small, it's not even worth talking about. Yeah, and then by the way, the UK Biobank study tried to look at its contribution to etiology. But polygenic risk scores in depression are about 3 to 7% accounting for variability. So I think we have been seduced to come up with a single explanation for what amounts to probably thousands of disorders. And we're trying, in fact, we're overfitting the molecular and the mechanistic understanding to all mental disorders. I therefore believe strongly that the link between inflammation in mental illness is not as interesting as the link between inflammation and dimensional psychopathology, like cognitive impairment and reward. And the scientific evidence is quite compelling that that is in fact a more robust association. And that obviously is transdiagnostic. So I agree with you. I think right now we still can only say that we have some lines of research that indicate etiology. In some cases, the UK Biobank work looks very interesting. We have insufficient longitudinal data to really show this in large populations. But I think there's a couple of premises here. The first premise is these are multiple disorders. And secondly, I think we have many pathoetiologies. And thirdly, I think the link is more to dimensions of pathology than it is actually to a mental illness. And that's why we keep getting frustrated. And that's why I also think that some of the interventions that use anti-inflammatory drugs to treat mental illness have had average results because we haven't had sufficient characterization of the biophenotype.
Peter? Afzal? Your.
Well, thank you very much. I think it is always a bonus to listen to Professor Mcintyre.
Thank you. Thank you.
You are absolutely right, and I'm fully convinced that although we try to say that we know a lot, but we really know a little. And the time is coming up that many of our medications will be equally helpful in treating many other non-psychiatric disorders, whereas medicines used for non-psychiatric disorders may be equally effective in terms of treating or managing many of our symptoms. And it's really a sort of a process that all of us are looking for and willing to really go through this route, that what is relevant today may not be very relevant tomorrow. Yep. And thank you very much for giving a sort of a very broad perspective. And I'm sure that this will be a sort of an eye-opener for many of us, that how changes and advances are taking place in the field of psychopharmacology. Thank you very much.
Thank you. Thanks for having me. Take good care. Thank you. Bye-bye.
Well, for me, it looks very interesting. Generally speaking, all this theory of inflammation and psychiatric disorders, and I just noted one very important thing which I discovered some months ago, when they start to publish the study on fluvoxamine as a possible agent to treat COVID complication, especially pulmonological complications, saturation and so on. Why? Because for the first time, and the basis of biological approach, the people tried to introduce psychotropic drugs for the treatment of somatic consequence of somatic illness. It was never happening before. Normally, the psychotropic drugs was discovered or occasionally, or it was discovered especially to treat our disorders. And here it is quite now it's more or less clear evidence that it's really have a double action, at least, because fluvoxamine, according to the data, which, by the way, it was just some weeks ago, it appeared a reproduction of this US-Brazilian study in Croatia. Well, they have probably some very adequate data, similar data, showing that utilization of our antidepressant give us some good results in post-COVID syndrome. Well, I don't know if it will be confirmed later on, but at least we could think about the new pathogenetical way of utilization of our drugs in some other field, and to think about inflammation as a common disorder, or even in the part of our pathology, common disorder for two different parts. Again, about concept of comorbidity and so on. Well, this is a really stimulating lecture, and I start to think again on this subject.
And thank you very much, Professor Fontourakis, for your efforts. You are really doing a great job of bringing the experts to the general public. So please keep it on, and please carry it on.
We will have the next Meet the Expert in early December. The program will be ready in the next few days, so everybody will be informed about that. Now, thank you everybody for being here with us tonight. The video of the webinar will be soon uploaded in the World Psychiatric Association website, and it will be accessible for everybody. Professor Morozov, Professor Afzal, Roger and Daryl is not here. Anyway, thank you all for being here. We will meet again next month. Good
Great.
night. Take care.
Thank you very much. Thank you.